What's up, everyone? I'm here with someone very special, near and dear to my heart, Dr. Christopher Doty. He was my program director when I was a resident many years ago, and he's cranked out some of the best residents known to emergency medicine. So I'm very honored to welcome Dr. Chris Doty.
I would have to agree that I have participated in the training of, I would consider, some of the finest emergency physicians on the planet. I also have known you a long time.
Yeah.
I knew you before you were famous.
I'm only famous in my own head. And I will say you put out the greatest residency class ever.
2001.
2008. We'll agree to disagree there. Okay. Tell us exactly what you do.
My title doesn't really reflect what I actually do. I am the former program director at Kings County Hospital, where we met, and then I came to the University of Kentucky as the program director and as the vice chair of education. And I still am the vice chair of education. I'm no longer the program director, but mostly what I do is vice chair of academic affairs. So I'm the vice chair of academic stuff here at UK. I don't do a lot of research, or the research stuff is the only academic thing I really don't oversee. So I do faculty development, promotions, I run the education division, and then interface with the College of Medicine. It's mostly education with faculty development and recruitment.
What most people don't know is people in your role, they basically do everything, right? You're the glue that holds the whole program together. And without you, it'd just be a lot of fragmented things happening.
The program director does all the heavy lifting, and then I try to support him and support the chair.
Yeah, you're very humble, but I know that you do a ton. So let's get right into it. And there's no better person I could think of when we got to this topic than you, because you, to me, are the quintessential emergency medicine physician. In fact, when I was a medical student, I rotated and I would just see you running around the department. Even before you knew who I was like, that dude is emergency medicine. So that's why I want you to be on here, because you are the embodiment. And also, I know you're going to talk and tell us like it is.
You have a habit of telling it like I see it.
Hey, that's why you're here. So let me ask you, what the hell just happened?
Yeah.
Match.
I think a lot of people felt like they were blindsided, but I don't think I was blindsided, and I think people that really pay attention don't feel like they were blindsided. So over the last few years, there have been fewer U.S. medical seniors, so people that graduate with an MD degree in the United States, that have gone into emergency medicine. So quite a few less this year, but there were less than had been. We had seen positive trajectory over the last many years. Really, since 1997, there was a sharp uptick in emergency medicine. And interestingly, that coincides with when the show ER came out. So that really bolstered the competitiveness of our specialty, but also the specialty grew and we came into our own. But over the past just few years, which also coincides with COVID, we saw a decrease. And then this year, we saw a significant decrease, more than really any other specialty.
So this was coming, is what you're saying?
Yeah, I mean, it was coming, but there are also a bunch of different variables. You know, it's a complex adaptive system. So when you change one thing, other things change within the system. It's much like human physiology. But there were a bunch of things that changed simultaneously over the past 2 years that I think had negative impact in our field. But in a lot of ways, I think what happened in the match this year, and just to be clear, that was a significant portion of unfilled positions, over 550 unfilled positions in emergency medicine throughout the country, which is head and shoulders above any other specialty. We account for about 8%, 7%, 8% of U.S. seniors that go into specialties in general, but we accounted for 18% of unfilled spots, so a 300% relative share of our unfilled positions. Now, some of those positions you never see, like dermatology and orthopedics. You really don't have unfilled positions. Emergency medicine has always had a few, which I would call a mismatch, because there are always plenty of people that want to go to emergency medicine that didn't get a position. And then we have some unfilled positions each year. But usually that's not many. And last year it was quite a few, less than 100, and this year over 500.
In its best year, in emergency medicine's heyday, and I don't mean that to say that the heyday is gone, but at its peak, when things were clicking and people who were AOA type of students were going to emergency medicine, what was the percent or number of spots that were unfilled for the scramble?
1%.
1%.
Yeah, there were always a few, and sometimes that was a program that had some issues or expanded or made some cognitive errors in making their match list. But there's always something like there are some special tracks, like the military and some companies abroad will have a position in the match for their group. There is a large company in Saudi Arabia that tries to train emergency physicians to go back to their country. So they help finance that position because it's not going to be paid for by CMS, the governmental group that pays for most GME education. So if somebody wasn't coming into that position, then that would look like an unfilled spot. So there were always a few of those. The military has some spots sometimes that going to go fill, but there are always a couple of those, but there are always a few, less than 10, that were open. But most established programs would not have that. And then whenever you had a new program that was opening up, especially if they opened up outside of the match, much like Kings County did in 95, that then you have some unfilled spots and usually fill outside the match. But those are people that got approval after they were a deadline to go into the match.
All right, so those factors that you talked about before, can we start going into them a little bit more? COVID is obviously COVID, and there's possibly nothing we could have done about that. Or maybe there was something we could have done in terms of the optics of emergency medicine. Remember when people were banging on pots and pans and EM was heroes? But let's go through one by one and talk about the impact that it had, in your opinion, and whether or not there's something that we could do about that. Because I hope the title of this podcast is not right. I hope EM is not dead. I don't think it ever could be.
It's not. It's not dead. But we do have a self-inflicted gunshot wound. And I do mean it. It's a self-inflicted gunshot wound.
Yeah, and that's what I hope to get into. And that's what I know you never mince words, so I know we're going to get right into it. I've not heard it called that just yet, but I knew Chris Doty would have a perfect terminology for this. So let's go.
Yeah, so the COVID thing, I think, matters. I don't think we'll ever know how much it matters, but I do think people were very concerned about being absolutely frontline for emergency medicine because you work upstairs in the ICU as well, and you can be particular about when you go in and see patients. You have more time to prep, perhaps, as long as they're not decompensating. But almost all the specialties can have somewhat scheduled interactions with their patients. Emergency medicine, you do not. They just come in the door, and if they're sick, you get PPE as fast as you can, but it is less scheduled interactions. And obviously, the people that are the sickest have the highest viral loads, and we're talking about way back in the Delta variant and even before that, we would see patients that were extraordinarily sick from a pulmonary standpoint, really knocking on death's door. And you're in that room for extended periods of time, trying to manage their hemodynamics and their pulmonary status, doing aerosolizing procedures like intubation or sometimes even suction if they have a bunch of airway secretions or loogies or whatever. You have to manage that. So I think that people saw that and it made people nervous. Medical students were actually forbidden in a lot of medical schools, mine included, to seeing those patients. That is a strong disincentive. We're like, we don't know if we want you to see emergency medicine patients that are COVID positive. So they were all COVID positive for a while. So that is an unwritten disincentive to people that are going into emergency medicine. So there was the COVID thing, and I was scared to come to work. I was just looking through, one of my former colleagues that's left posted something on Facebook from a couple of years ago, and he said it was the first time that I'd ever really been scared to go to work. And I thought back and I said, yeah, I was scared to go to work too. And I used to get completely naked in my garage before I came in the house, down to my underwear and socks. So there was that. And I don't know what effect that had on people that were thinking about the specialty, but there is that.
Let me hold you there, because what's interesting about that is that could almost go in two different directions, where EM was showing up, doing all these procedures, certainly the media covered, doctors and nurses and everyone involved, pre-hospital folks getting in gear and taking care of people. Yeah. It could have been one where there was a great boon in emergency medicine. So these were the people that didn't run away. These were the people that showed up. We lost, and we know people in common who we lost as a result of the pandemic. It could have been that way. But why do you think it went?
I'm sorry, I didn't mean
the other way?
Yeah, I think it's hard to know. I do think there are, and I hope to count myself amongst these people that are true believers in the field of emergency medicine and want to show up and want to soldier on and take care of people. There are people that believe in the mission, the vocation of taking care of our most needy patients. So I think there may have been some people that came that way and increased the interest in emergency medicine. But there was a lot of fear, and I think some people that turns them off to think about, oh my God, there's so much that could go wrong. And how do you bring this home to your significant other, to your partner, to your children? My mother had pulmonary hypertension, awful disease, terrible disease. And I was just absolutely sure that if I went to visit her, that I would kill her. My children, who are young in grade school and preschool, would kill her. I just don't think she would have survived. So I think you're right. We don't know what effect that had. But there's this other piece that happened with COVID. And that is that, and this is the self-inflicted gunshot wound part of it, is that we in emergency medicine have been talking crap about our specialty for quite some time. And this has been going on for 5 or 6 years. There was a large study that came out, commissioned by the large organized groups in emergency medicine, and the American Board of Emergency Medicine, the American College of Emergency Physicians, the American Academy of Emergency Medicine, all came together along with our resident organizations to help get this workforce study out there. And I think it was pretty flawed. And the flawed nature of the study may go beyond the scope of this conversation. But basically what the study said is that the career aspects are saturated, that the places where people want to move to, it's harder to get jobs now than it was 10 years ago. And 10 years from now, it's going to be even harder. There are too many emergency physicians for the population. And when I read that, I thought, no effing way. That's just not true. And granted, I work in a more rural state. I was in New York City, and it's probably true for New York City. It's probably true for Los Angeles or California. Colorado, like everyone I know wants to live in Colorado. But it's certainly not true in rural Kentucky. There are tons, and by tons, tons and tons of positions for people that want to work in emergency medicine. And I think that's true of a lot of places when you get out of the large metropolitan areas in this country. I think that was a big issue in that we put out a flawed study that said your job prospects may not be great. That was on top of a real thing that happened with COVID, where the year that COVID happened, a lot of emergency departments census, and this does not apply again to the East Coast, but dropped. Like our census dropped by 42% at UK. So people just chose not to come to the emergency department. And it hit in February and March of that year, 2020. And our census went down, and we had to actually make changes in our staffing because we didn't have enough patients to support the number of doctors we had. And that particular year, there were a lot of emergency physicians that were graduating residency that did have some trouble for the first time in a while getting a job. So I think that happened, and people were public about that. The graduates were public about that. So now we have this workforce study and a real singular year of people having trouble getting jobs, which actually, by the way, has not extended past that time. 21 and 22 were not that difficult to get jobs, and 23 is not difficult. And then there probably is a burnout issue in medicine in general, and that is also true in emergency medicine, simply because when we look at burnout in medicine practices, it's usually associated with people that have more acute patients. The surgical specialties, particularly trauma, cancer surgery, pulmonary critical care, emergency medicine, urology actually is pretty high. And with the exception of the pediatric critical care, most other acute care specialties are having burnout issues. And emergency medicine does have some burnout. I have a lot of strong feelings about why that is. I never think emergency medicine gets as much credit as it should. But the issue is real, and I think hospital institutions have not met the need to fix the wellness issue that is rampant in all specialties, but certainly within emergency medicine. So we've been telling people there's a burnout issue, and we are not empowered as emergency physicians to fix this problem. By the way, we had a year where many of our grads had trouble getting jobs. Oh, and there's a workforce study that's out there. And emergency medicine's hard. So we sometimes vent and I just did it not 90 seconds ago, complaining that we don't get the credit we deserve. So when we talk about this, our specialty in this way, people listen. So what I've said several times since this match is we've been talking crap about emergency medicine for a long time and how hard it is. And finally the medical students listened, and now we're surprised and sorry. So that's what I mean by it's a self-inflicted gunshot wound.
It certainly makes sense. The medical students, we sometimes think that they just come through and they do the rotation and they see a cool lac repair or an intubation. They're just wowed. But they are doing a lot more research into what this means the long term in terms of, you say burnout rate is high. Do I want to buy into this when I see that the job market's declining? Is this something that I want to invest time into? And so with these forums, these boards and social media, all of these things become amplified. And sometimes it goes in the other direction where fear gets overblown, where now it becomes irrational fears. I'm definitely not going to do that specialty. But there's an understanding out there that this might not be the specialty for them. And so before we go on and talk about some of the other factors that might have contributed, is there anything you think you can do to mitigate that, to stop that burn, to PR campaign for emergency medicine again, if you will, to get it back in the news? Because like you said, ER, I'll be honest with you, ER was one of the reasons why I did emergency medicine. As silly as that sounds, you'd watch that show and you'd be like, this is really cool. I had no idea that this existed. And I'm going to go do a rotation on it. And it was amazing. So what's the PR campaign to reverse all of this?
So I think that we have to be on message about what I believe to be true, that emergency medicine is a specialty where you get an opportunity to help people in their worst time, in a time full of impact, where people come in sick or hurt or scared, injured, and you get an opportunity to help them every day. So what a normal Tuesday for that emergency physician is a day like no other for that patient, where their mom is injured or their child is hurt. And I mean, what an opportunity to be able to interface with the other people in the world, citizens, a chance to live a life of service. So I think that is a huge deal. And what we've seen with longevity studies is that this doctor-patient interaction and the sense of purpose is a huge deal. And I just don't think you find that in all specialties. And maybe I'm egocentric because I'm an emergency physician. And when you said I'm the quintessential emergency physician, I don't know if that's true, but everything about me is typical emergency physician. The way I interface with other people, my sense of dark humor, the way that, that I interface with other people in the hospital, my adult ADHD. It's all very typical emergency medicine.
But also your bedside manner and how you approach patients who come in the emergency department. I can't tell you how many Dotyisms are in my head every time I see a patient and I'm not paying attention to the respiratory rate. It's like Doty said, always beware of the risking tachypnea. And then that's the stuff I impart to my residents and medical students.
That makes me happy.
Quintessential in so many ways. Then we have to ask, is there anything else? Is there anything else that caused this, I'm going to call it a disaster? Is there anything else that happened besides burnout, besides
there are a couple
markets?
Yeah, but there's one other thing, part of the PR campaign that I don't want to give short shrift because I think it's huge, is there are still tremendous job opportunities for emergency medicine, not just to get jobs. I do think that there's lots of jobs to be had, but what you can do after an emergency medicine residency, I think, is huge. So you did a combined program, EMIM, but then went on to do critical care. But with emergency medicine, you don't have to do EMIM programs anymore. You can go on to do critical care. You can do palliative care. You can do sort of specialties in obesity medicine, in occupational medicine, administration. Point of care ultrasound is a huge deal for our field. It's gotten to the point where you don't even have to do a fellowship anymore to be really facile in point of care ultrasound. That's one of your big things. You never did a fellowship in that. You were certainly trained in it, and your fellowship was in critical care. So I think that you can step into a bunch of things, MO roles, CEO roles. There are tons of deans, vice chair of, or vice dean of medical education. Like, we have a ton of possibilities for a relatively smaller specialty. If you look within medical schools, you look within the leadership C-suites of healthcare institutions, there's a ton of emergency physicians around. Our upward mobility is pretty impressive. So I think that the job opportunities you have after residency and to supplement your practice, to be a CMO and also an emergency physician, or to be a vice dean of medical education or admissions and also a practicing emergency physician. And then there are a lot of people that have side gigs where they do. I know several emergency physicians that do education, particularly ultrasound education, as a side gig, as a company. There are lots of people that have side gigs in doing, I'll call boutique medicine, where they have these not really urgent cares, but clinics, hydration clinics and things like that, where they're finding ways to serve different populations and maybe less stressful patient interactions for part of their clinical practice. So there's a ton that you can do with emergency medicine.
You can even start a YouTube channel. I completely agree with you. Everything you're saying is resonating. I hope that medical students are listening to this, or people who are pre-med even, who are thinking about medical school, are listening to this, because what you're saying is absolutely true. What other problems came out of this that are identifiable and possibly reversible?
So the workforce study and this group called Take EM Back has talked a lot about scope creep of mid-level practitioners, whether those be nurse practitioners or PAs. So a lot of people say you're all just going to be replaced by PAs and nurse practitioners, and I don't think that's true. Now, I'm a physician, so I believe that physician-led teams are the best and provide the best care. But I think there's a place at the table for all those groups to provide excellent patient care and allow this is what we call them. I used to call them mid-level practitioners, but they don't like that name, so that's fine. But advanced practice providers to supplement and synergize with us. So I think the workforce study also brought that concern to light and gave it some legs a little bit. I don't think it's a big issue. I think that most places, if given the chance to hire an NP or an emergency physician, are going to choose that board-certified emergency physician. There was a lot of talk and a lot of blame on corporate emergency medicine groups opening residencies, and it's a problem. So there's a group, a for-profit organization called HCA that opens residencies. I do think that is not great for the specialty. I do think that they are they have financial goals in mind when they do that. They say that they're trying to bring healthcare all over, but I think opening residencies affects a short-term and a long-term goal for them. The short-term goal is to staff their emergency rooms, so they have cheap labor when they're residents. They have plenty of labor to fill their emergency departments 3 years from now. And then long-term, there's a lot of residents to be emergency physicians, which creates market forces that drive down the reimbursement for emergency physicians 20 years from now. So in a lot of ways, I think they're playing a short-term and a long-term game.
Is there any benchmark for these new residencies that come out? Are there any metrics that the organizations who run this, the ACGME, says that we got to raise the bar up here?
That is some talk on how to fix this problem, is to increase the requirements on programs. So the ACGME and the subsection of the ACGME called the Residency Review Committee, or RRC, guarantees the quality of programs. So the ACGME says that we don't deal with workforce issues. What we deal with is accreditation. So if you meet the bar, then you are accredited, period, full. And the RRC for emergency medicine is the ones challenged with doing that. So you have a group of seasoned emergency physicians that sit on the RRC, and the people on those committees, he or she looks at each residency and decides, are they meeting the criteria or not? So there is that. Like, you cannot open a residency, you cannot get accredited if you're not meeting the minimum standards. So one of the ways to maybe affect this is to increase the minimum standards. Now that has problems too. There are always unintended consequences to every change. And maybe there are good or established programs, if you raise the minimum standards, have issues meeting those standards. Now, one could say, why is that a bad thing? If the minimum standards have to do with EMS, or have to do with point-of-care ultrasound, or have to do with trauma numbers, procedures, then there are programs that may not be able to hire an EMS director, or they don't have enough people interested in point-of-care ultrasound to meet the needs and have the infrastructure that's required. But that would certainly decrease the number of programs if we increase the standard for each program to meet. I think that at some point, because I believe that Team Health and HCA are making financial decisions, not social decisions, but financial decisions, whether this makes sense. And I think if you increase the requirements, then, it becomes less financially advantageous to open a residency.
What else have you identified in this bigger problem?
So there is one other thing that has not really been talked about at all, and that's the increase in the size of programs. The RC looks by simple mathematical and common sense determinations. Do you have enough procedures? Do you have enough core faculty? Do you have enough patient volume to sustain 50 residents rather than 30 residents? So there are programs that have made large increases in their size, and myself included. So the University of Kentucky, when I started here 10 years ago, had 8 residents for 3 years. We now have 13 residents for 3 years. So we have increased significantly over the past decade the size of our program. We have plenty of resources to go around. It's a great place to train residents. There's lots of trauma and procedures, and we've been able to hire outstanding faculty here. But other places are doing the same thing. We did it at UK because we want to train more emergency physicians to work in the Commonwealth, and because I, and along with the chair, felt like we needed a bigger program to really make an impact in our local environment here. But there are plenty of other people that feel the same way. There are programs in New York City even, which is somewhat saturated with programs, that have grown tremendously over the past 3 to 5 years. Most chairs and program directors don't want to decrease the size of their programs. In fact, they may want to increase the size of their programs because they feel like there are a lot of patients to be seen. And that goes to a larger question, is whether the emergency department is the right place for us to have a safety net in our society. But clearly that's where it is. And as our healthcare system in America gets more and more broken, which I think it is somewhat broken, the outpatient healthcare system, the emergency department is more and more relied on to help those patients. So a lot of programs feel like they need larger residencies. But that is a big deal. So you have entire programs that are opening that increase the number of available spots. You have present programs. Some of those were fairly established programs, good programs, that did not fill in this past match. They may be increasing their spots, or they may have some issue with that particular program that year that caused them to not be able to recruit well. And program directors live and die by who they recruit to the program. A single bad year will stay around for 3 or 4 years, and that has downstream effects. So if you have a bad year with a particularly class that's not quite up to standard, the next class that comes in will have some influence from that, whether that be in recruitment or in actual practice. It takes a little while to recover from a bad recruiting year. So I think we're all having recruiting years that are not fantastic. The quality of applicant was not quite as good, and the number of applicants was relatively less than what we needed. So I think this wound, the self-inflicted gunshot wound, will heal. I think it's going to leave a scar, and I do think that we will be better after this sort of passes through. But I also think that this has been seen before. I matched into a program in 1997, and at the time, anesthesia was going through this very thing where nobody wanted to go into anesthesia. They felt nurse anesthetists were taking over the entire specialty, and it was essentially a dead field. But look at anesthesia now. They're doing great 25 years later. So I think they also had to go through a difficult time, but I think they're stronger and better because of it. And I think that'll happen to emergency medicine.
Do you think that the future of emergency medicine is this further subspecialization, not just as a tactic to improve the candidates that come in, but as a maturity of the specialty, which is still in the grander scheme of things, a relatively young specialty?
Yeah, it is, but I think we're doing exactly that. The growth of point-of-care ultrasound and emergency medicine has been meteoric. I think we're also doing more of our own procedural sedations. Like, we just don't ever call anesthesia to do procedural sedations for us. Other ERs may be different, but certainly we've made that change. We're doing observation medicine and emergency medicine. And we presently have an OBS unit at the University of Kentucky. So I think we are expanding that. We have toxicology clinics now, occupational medicine clinics. We have a high-risk discharge clinic for emergency medicine where people can come back after a higher risk discharge to have something checked, a creatinine, if they had a bump in their creatinine. It was probably pre-renal azotemia. So we hydrated them and bring them back in a couple of days and make sure that they don't have acute kidney injury.
So I think what we're saying here is that emergency medicine is not dead. This is certainly, I don't want to say a dark period. It's certainly not a great period, but this is incentivizing us to look to the future for great leaders like you and thinkers who know the specialty well to help us to right the ship.
I think it's a growth period, Haney. I think that growth comes in times of pain, and this is a tough time for us, but it's a time where we can redefine and focus. And I do think that one of the things that you may have heard me say at some point is pain is a sensation of weakness leaving your body.
I've heard that many times from you.
Yeah. So I do think that we have an opportunity to be better.
No better place to end the podcast than right there on that statement. And so I thank you very much for being here today and for imparting so much wisdom. It's always good to talk to you, but I just want to give everyone out there just a window into the amazing person who helped train me. And
I take full credit, Haney. It wasn't all me, but you are absolutely doing great things, and you are a testament to what people can do when they commit to being as good as they can be. And as much as I give you a hard time about your class, there's a bunch of them in that class at the county.
I couldn't agree with you more.
Yeah.
And by the way, he was paid to say those exact words.
It still wasn't as great as 2001, but it was a good class.
Agree, disagree, but that's great. All right. Really good to see you.
I love talking to you, Haney.
You too, my friend.